Good evening, everyone, and thank you all for joining us for tonight's COVID-19 update webinar. My name is Beth, and I am joined tonight by our panel from the RACGP and the New South Wales Ministry of Health. Welcome Associate Professor Charlotte Hespy, Dr. Penny Burns, Dr. Kerry Chant, Professor Christine McCartney, and Dr. Kedaki Sharma. Before we get started, I would just like to do an acknowledgement of country. We recognise the traditional custodians of the lands and sea on which we live and work. We pay our respects to elders past, present and emerging. I'm now going to pass you over to Dr. Kerry Chant to provide us with a COVID update. Thanks, Kerry. Sorry, Kerry, you're just on mute.
Yep. Thank you very much, Bethany. And I too would like to acknowledge the traditional custodians of the land on which we're meeting and pay my respects to elders past and present. In terms of the general COVID update, just in summary, we're in a period of no community transmission, and we dealt with 3 incursion events. One of those was in a driver associated with transporting flight crew. That transmission event does not appear to have led to any on-transmissions. We were dealing with another event associated with a seeding event in Avalon. We don't know the source of that and how that originated, but it was clearly amplified by 2 hospitality settings, the Avalon Bolo and the Avalon RSL. And then we saw subsequent transmission at gyms, hospitality, and some level of community transmission within particularly the northern zone of the Northern Beaches. There was a range of strategies put in place, which was really around rapid identification of cases, so achieving very high numbers of testing, isolating those cases and quarantining contacts. And also we implemented a range of restrictions. The aim of this is to actually reduce the risk that even if we missed cases, they were less likely to lead to super spreading events. And overall, we're trying to change the R effective or the reproductive rate that was occurring so that we could lead to achieve no community transmission. We also had a third event that we were dealing with, and this was in a patient, in a healthcare worker who was involved in the transport of patients. And that healthcare worker subsequently, there were a few different chains. It was also some workplace transmission. And then we ended up having a seeding event where workers at the BWS at Baralla were infected, and then some workplace transmission within that workplace, leading to amplification and some community exposures as well. We're in the final stages of mock. We have not seen any Avalon cases for probably in excess of around bordering on 10 days to 2 weeks. But we have on the weekend seen some cases originating that were genomically linked to the Baralla cluster, but no clear path of transmission. Investigations are ongoing. So in summary, the picture is that we have, when we take into account the intelligence from our testing, our sewage surveillance, we would conclude that there is the risk that there might be some low level of transmission occurring in New South Wales, particularly in the southwestern and western parts, but that we need to maintain vigilance across the state as we try to mop up any undetected chains of transmission. And I suppose a key message to general practice is please test. I understand that it's a low pretest probability that it has COVID, but just as an example, when we find one case in a household, we often, particularly in southwestern Sydney and Western Sydney, where there is more likely to be multi-generations living together and larger household sizes, that we often find many cases, and that's what occurred on the weekend, leading to about 7 people that were diagnosed. So in summary, low community transmission setting, but certainly a high risk level that there may be some undetected chains, and we need your assistance in getting those testing rates high. Thanks. Thanks, Bethany, and did you want to move on to the presentation in relation to immunisation, or hold it there? Okay. So we move to the next slide. Just wanted to give you, we're now fortunate to be discussing vaccines. We've discussed vaccines at previous meetings, but more with a vision to the future, but now it's a realistic within the horizon, a short-term horizon for us. So just to remind people that all vaccines must pass stringent evaluation process before they're reviewed, approved, and the TGA is the Australian regulator. That registrations based on the safety, quality, and effectiveness of the vaccine, and also ongoing submission of comprehensive clinical data about the stability and other information. The Therapeutic Goods Administration assesses all vaccines before they can be used in Australia and continues to monitor and evaluate the safety of vaccines. And we should be assured that the TGA has been in active engagement with regulators across the world to get the best and most contemporary information on the real life experience with vaccine rollout, but also have been engaging actively with the companies. Next slide. So in terms of New South Wales, before going on to this, I might just talk a little bit about the vaccine rollout in Australia and what we're planning for in the short term. The Commonwealth has obviously released the blueprint for vaccine availability and indicated that the 2 candidate vaccines that we're likely to have access to and be using shortly is one, the Pfizer vaccine, and the second being the AstraZeneca vaccine. The plans for the Pfizer vaccine is that states and territories would roll that vaccine out. And the estimated time is in once there'll be a period after the TGA has approved that the company will deliver that to Australia, and then we'll have be able to fix a precise commencement date. But that's certainly looking plausible for a rollout in February, late, towards the end of February. And what we're looking at there is rolling out that, particularly to the states being responsible for rollout to quarantine workers or workers that are at high risk of exposure associated with international air crew, coming in contact with passengers arriving from overseas. So that's the whole end-to-end transmission, whole end-to-end process of how people returning come in, also cargo crew. So people that might be in contact with people who inadvertently may be infected are considered a really high priority for it, as well as those managing our quarantine hotels, and they will be in the first 1A rollout, which the state will be responsible for. We'll also be responsible for vaccinating healthcare workers who are at significant risk of seeing COVID patients. And so that will be people in the private and public system that are doing manning COVID testing clinics, also our emergency departments, critical care, our other services that support our emergency departments, such as radiography, venipuncture services, and other allied health that would be present and likely at risk of exposure in that setting. So that will be very much what the state's responsible for. We will also take responsibility for vaccinating our own aged care facilities, which is a very small number of aged care facilities overall. The Commonwealth is taking responsibility for aged care sector and the disability sector outside those limited state-run facilities. So we've been doing a lot of work with the New South Wales vaccine safety and surveillance systems, because a key role is going to be providing that information to continue to reassure the Australian population as well as the clinicians that the vaccine, that we are taking vaccine post-marketing surveillance very seriously. We're very lucky that we have the National Centre for Immunisation Research, NCIRS, and we've been closely working with NCIRS. So just to remind you that adverse events are a notifiable condition and must be notified to public health units. And then we're also establishing more active surveillance systems. So AusVax Safety is a system that sends automated messages either via Vax Tracker or Smart Vax to a person who's received the vaccine, and they're able to monitor for and report adverse events or their experience of that vaccination. And also we'll be using the public health real-time emergency syndromic surveillance to look at where there may well be events associated with immunisation. Next slide. So how SmartVax works is that software installed and runs in the background of your practice software. It sends SMSs to patients 3 to 5 days after vaccinations. Patients that accept the initiation complete a survey if they've experienced an adverse event, and GPs are notified via their practice software inbox of any medically attended actions. So what we're encouraging you to do, I suppose, is to sign up for SmartVax. We would like to see very significant participation for GPs in the SmartVax system, as we do want a comprehensive active surveillance system around the vaccination system. Next slide. So when to report an adverse event following immunisation is report all uncommon, serious or unexpected adverse events or any event felt to be clinically significant following vaccination. And those circumstances are listed there. Also, any medical event that requires intervention to protect one of the outcomes above may also be considered serious. Deaths occurring within 6 weeks of vaccination where it is plausible that a vaccination contributed to or caused the conditions causing death, and this timeframe is a guide only. If a death occurs outside this timeframe and meets the criterion for a serious adverse event, should also be reported. We're expecting a high rates of reporting of adverse events, so it is important that when you hear some reporting of those numbers, that it isn't actually seen as associated with the vaccine. We will then initiate a process to look into all of these adverse events. Next slide. So in terms of how to report, as I said, we're encouraging you to sign up to the AusVax safety program via the SmartVax, and then report the adverse events to your public health unit in the usual way. And there is also reporting provisions on the TGA. Next slide. We're also conscious that you may want to seek clinical advice for you or your patients, and guidance can be sought through the local public health units, and that might be in, is this adverse event notifiable, or if you want any generalist advice about vaccines and COVID vaccine in particular. We're very lucky that we also have this New South Wales Immunisation Specialist Service, which is run by NSWS, and so we can provide specialised immunisation advice and consultation. And there will be a centralised COVID safety hotline for patients. Next slide. So healthcare professionals play an important role in facilitating vaccine uptake, and communication is the key. And I just acknowledge that this is probably one of the first times, or progressively we'll be engaging you with in discussions around the vaccines. But it is important when a patient raises the fact that they might be concerned about a vaccine side effect, that their issue is acknowledged and empathised, so that we can build trust and rapport, engage in active listening, and then also that we discuss with them around the risks and benefits. Christine from NSWS will talk about some of the decision support tools that may be made available to you for particular difficult conversations in frail elderly, those with pregnancy, and particular areas where people might have particular concerns. We also are conscious that sometimes people get attributed as, we know that many things occur to people in terms of hospitalisation or key health events, and that they might occur in a time frame in temporal association with the vaccine. But it is clear that we report those where you, and there's also ability for your patients to report them but we will then have a process to actually look at causation. And I suppose taking the opportunity to explain the difference between the fact that many, you know, particularly with an aging population with comorbidities, medical events can occur, but it doesn't mean they're necessarily attributable to the vaccine. And that we take those things seriously and we'll work through a process. So next slide. That's all I had to say, and I'll defer to Christine and Kataki to go more in depth about the vaccine and what you need to know.
Christine, do you want to talk?
Did you want to, or Kataki, did you want to go first? Who would like to go first?
Look, thanks. I mean, I'm happy to make a few comments, and then obviously, you know, happy to answer questions as well. As you know, as Kerry outlined, we're still awaiting for the registration of the first vaccine in Australia. It's likely to be the Pfizer vaccine because, as you know, it has been stated that's the first being reviewed by the TGA. And but even once that announcement comes, it'll still be some time. You know, the vaccine's got to come into the country. It's got to be batch tested, and then released and distributed. And that is, of course, the -70 vaccine. That's why it's going to those Pfizer hubs that you know, Kerry spoke about. I think also, you know, I get the sense that people are really wanting to see the clinical guidance at this stage, but it's very important that that clinical guidance is it's populated with the latest information, and that information comes right at the point that it's registered by the TGA. At the National Centre, we of course work in support of the national program, and you know, that clinical guidance is in a very advanced stage. It's all going to be delivered, you know, nationally with all of the whole program materials, and then obviously, you know, materials refined by and delivered within New South Wales, which has an outstanding record of delivering vaccines. I'm not just saying that to butter up Kerry, I really believe it. So, you know, I think it's not too far away, but, you know, there are a number of things that we already heard about in terms of, you know, readying your practice, ensuring that you're very familiar with things like, you know, protocols for, you know, the kind of informed consent processes, screening patients, you know, obviously, you know, ensuring that you're up to date with your, you know, staff are up to date with, you know, even immunisation training. That we do understand there'll be training packages and training, a lot of training information coming from the Commonwealth as well. And it'll be specific to each vaccine when they're registered. But I think obviously just things like refresher practices and training in treating common adverse events and uncommon adverse events. I mean, we know that anaphylaxis can occur in up to 1 in 100,000, you know, vaccine doses. That's kind of the rate that is being reported for the program out of the United States, 1 in 100,000. Now, you know, we need to even hear more data on that, but that's rare, but it's obviously manageable and treatable. So I think it's things are getting closer. The other areas where we know we don't necessarily have data from clinical trials, and it might be more of a shared clinical decision-making environment because of the looking at the benefit risk profile, is in some of the areas that Kerry touched on. So say in the very frail elderly, you know, in nursing homes. Now, you know, we do have some data in the elderly, you know, particularly, you know, for the Pfizer vaccine, you know, some data for the AstraZeneca vaccine, more data on the AstraZeneca vaccine coming in and possibly, you know, available soon. But of course, the most important thing there is that, you know, we've also seen the largest burden of COVID-19 in the elderly, a very serious condition if this is in aged care facilities. So balancing that up will probably be supported by some sort of clinical decision-making tool along with the usual clinical guidance. And then same for other groups like those with immune compromise or indeed chronic autoimmune conditions like your multiple sclerosis patients where they might have a concern about, you know, flares and the like. And obviously, you know, we're trying to seek as much information on the experience in using these vaccines as possible from our international colleagues. Then the third area Kerry also mentioned would be pregnancy and breastfeeding. Again, this is, the vaccine, particularly the Pfizer vaccine, is a non-live vaccine. So it is, we routinely use non-live vaccines, some of them in pregnant women, like influenza vaccine and whooping cough vaccine. So on first principles, it will be reasonable to consider administering to pregnant women, but they will no doubt have questions, and there should be a shared clinical decision-making tool around that we're hoping to develop and have available nationally. So lots still to come, but I think it's it's exciting. We're almost there, and general practice is going to play a very important role.
Thanks, Christine. And I think we're getting a number of questions coming through around the specific vaccines. I wonder, Kataki or Christine, if you wanted to just maybe mention a brief summary of the vaccines that are being considered. And there's been some questions around the side effects and who shouldn't be getting the vaccines as well.
Sure, I can just give you a brief overview of where we're up to globally in vaccine development and the program rollout. And I just wanted to highlight a couple of pieces of information that I thought providers would find really useful to share with your patients and things that you might be already getting asked. So firstly, over 39 million doses of COVID vaccine have been administered globally across 51 countries. So that's fantastic and means that we're getting a lot of safety data. We're very lucky in Australia that we can see this happening in those sort of countries that are worse affected than us before we actually get the vaccine here. And so that means a lot of rich safety data is being collected. There are 9 vaccines that have had regulatory approval of some sort in at least one country. The vaccine that is approved in the most number of countries is the Pfizer vaccine, and that's the one, as you know, we're most likely to get first. For those who don't know, that's an mRNA vaccine. The other most commonly used vaccines currently are the AstraZeneca vaccine, which is a viral vector vaccine. I saw one of the questions in the comments was referring to whether or not it's a DNA vaccine. So actually none of these vaccines that we're currently considering to see in Australia this year are DNA vaccines. So the mRNA vaccine, the Pfizer vaccine, it cannot incorporate into our genome. It stays in the cytoplasm. It doesn't go into the nucleus. It just gets translated. And in fact, mRNA gets degraded very quickly. So that's one of the positives in terms of its safety profile. The AstraZeneca vaccine is a viral vector vaccine. And it actually is also what's called a non-replicating viral vector. So what that means is that the code for the spike protein is carried by a virus that can take it into the cell, but then it can't replicate and spread to other cells. So that's another sort of positive on the safety point of view, which means theoretically it should be safe for immunocompromised people as well, although it hasn't in the clinical trials. Only limited groups of immunocompromised people were included. So then those are probably the two that we're looking at in the immediate sort of future in Australia. But the Moderna vaccine has also been provisionally approved in some countries, as well as a number of inactivated COVID vaccines that were developed mostly in China, and a viral vector vaccine developed in Russia. So overall in the development space, there are 236 COVID vaccine candidates still in development, 63 in human clinical trials, and 15 in phase 3 trials. And this has already been mentioned, but we do have in Australia, we're more likely to see the Pfizer vaccine first. AstraZeneca, obviously we have a deal with the company to have supply in Australia, and possibly later this year, Novavax. And that is a protein subunit vaccine that's also on the FDA fast track approval process in the US. I also just wanted to draw your attention to a couple of resources that might be useful, and I'd be happy to share links to Bethany to email out. One is the Australian government has published a COVID-19 vaccine rollout strategy, and that actually contains detailed information on which groups are prioritised and some stratification. So that might be really useful to have a look at. It's a very simple document, as well as some information on the actual planning of the implementation of vaccination. The second thing I wanted to mention was just there's been some discussion in the media about the efficacy comparison between the Pfizer and the AstraZeneca candidates, and I'm sure Christine might be keen to comment further on that. But there's a really useful statement that was released by the Australian Academy of Science, which is a really sort of lay language summary explaining that both of these vaccines are very effective against severe COVID-19 disease, hospitalisation, transmission and death. And that's the key take-home message that we want to get across to people, and that although we don't currently know the efficacy against transmission very conclusively, even if it's not effective against transmission, a vaccine that is protective against severe disease, hospitalisation and death is still incredibly valuable. And so it still is a very effective vaccine. And having wide uptake of such a vaccine would still prevent us from facing the scenarios that we're seeing overseas. So that's a really useful document to look at. And then finally, Christine alluded to what has come out again in the media about some anaphylactic reactions following the Pfizer vaccine. So there is the US, the CDC has released a report giving more information on the cases that they have seen based on the US vaccine safety register called VAERS. They have had 21 cases out of over 1.8 million doses administered. So that is a rate of about 1 in 100,000. About 80% of those patients had a past history of some allergy. 7 of those had had a previous episode of anaphylaxis, and 71% of those cases occurred within 15 minutes of vaccination. There were no deaths, although 4 of those cases were hospitalised, and they only had follow-up data on 20 people, but all of those had recovered and were discharged. And the median interval to the onset of their symptoms was 13 minutes. So I thought that was useful information to know. What we're seeing in some other countries is that they are recommending anyone with a past history of severe allergy be observed for a bit longer, such as 30 minutes. And so obviously we don't have our guidelines in Australia yet, but that's just to give you an update on what we're seeing overseas. So I'll hand back to the team to field questions.
Thanks so much, Kataki. Can I just get a little bit more information too, in terms of, have you had any more information about the stuff that came out over the weekend about the 30 deaths with the frail and elderly? I must say, just a personal reflection, I found it interesting that if they were very frail and expected to die in the next few months, why they'd actually been given a vaccine rather than, anyway,
I'll hand that one to Christine.
Okay, thanks.
Yeah, look, I'm happy to speak to that. I think, you know, Norway have flagged themselves that they're not alarmed. What they have committed to in Norway is publishing a weekly report of all the adverse events that come through to them. And remember, there will be many coincidental events that occur. They might be, you know, having diarrhea or vomiting. We know, for example, that that's not more common after the vaccine than the placebo. It might be, you know, a death. And I think, you know, GPs know more than anybody that, you know, many frail elderly in nursing homes might not have much longer to live. I think, you know, we don't know that these were causally related events. Kerry spoke very clearly about the fact that we will see a lot of events that follow immunisation but aren't caused by immunisation. So that's still being investigated in Norway. And I think there's been information available that they've had, you know, they've vaccinated over 40,000 elderly in Norway. So, you know, that number represents a small number, and we have to look at how that compares with the usual daily or weekly, you know, rate of death in Norwegian aged care residents. Why would they have vaccinated those aged care residents? Well, I think there's 2 things to think about whenever we offer a vaccine. One is obviously the benefit to the individual, and you know, that benefit about severe disease, and obviously that's, you know, related to safety. You want to you know, have a benefit over any potential harms, and we don't know whether this vaccine has caused the harms of, you know, so there's a potential benefit for those residents. And the second thing I think is, you know, there's potentially a benefit for the nursing home environment, obviously, that if there are a number of residents that are protected, even if they're expected to perhaps only be alive for another year or so, you know, that's going to protect everybody else in the nursing home from transmission of that vaccine, of the virus. So I think these kind of concepts will probably come out in the decision-making tool, but I would just absolutely say that we don't know that those deaths are caused by the vaccine. They've been reported after the vaccine, not necessarily caused by them. And there is more information that will come from Norway, from Europe. As Ket mentioned, you know, the vaccine's been prioritised in aged care facilities across the world, and it has been largely the Pfizer vaccine. And we haven't seen this sort of signal come from the United States, from the UK, from Europe, in other places in Europe. So I think my gut feeling is this will probably be quite a lot of coincidental deaths, but, you know, let's wait and see what their investigation shows.
Yeah, thanks, Christine. I mean, I must say that was my feeling too, was that it was an coincidental, and maybe they had a slightly different profile of who they were vaccinating to. So thank you for that. The other sort of thing that I think people do have concerns about is the sort of the storage of vaccines in the general practice and how we're going to do it, etc. And I suppose I'll quickly put in that from a GP perspective, I think we need to just sit and relax, because the first stage isn't going to be us, and it is highly unlikely that GPs will have to do anything with the Pfizer vaccine within their own surgeries. And the plan is that it'll be the AZ vaccine, which is stored in the same way as we do all other vaccines. I'm seeing some nodding of heads, so just that we're all on the same page for that. So please don't get panicky about how you handle a -70 vaccine, nor about any of the stuff that's coming out about how it gets administered. That won't be a general practice problem. We will have more people to have to vaccinate, but it'll presumably, if it is the AZ one that gets approved, it'll be a more straightforward process, but that is an evolving picture.
And I would say there's, you know, do start to think about like kind of patient flow and clinic days and things that Kerry alluded to, because it is a multi-dose vial, you know, for even AstraZeneca, that is the vaccine that we think is most likely to be approved for general practice. And, you know, there'll be a lot of training and how to use that multi-dose vial. It's only going to have a very short window that you can go into the vial, you know, a very short number of hours, can tell you exactly how many. And, you know, but you'll have to think about sort of bookings, patient flow, all of those sort of things. But that guidance is all going to come. That guidance is all going to come from New South Wales Health, from the program in advance.
Yeah, I think there's a lot of questions here around education on multi-dose vial use and checklists and consent lists. And yeah, I agree. I echo what Christine says. Through the college discussions, we do know that this is all going to be coming out later on, and it'll be coming out in time. So I don't think we need to worry too much about that at this stage. But I agree. I think it's more about getting ready. It's like you do for the flu vaccine clinics, just really getting everything organised. Which leads me to a question around the actual administration of the vaccine and flu, and how, you know, the flu season's coming up as well, and how, I don't know whether Christine, you're the best person, or Kataki, to talk about, there's a little bit about doses, about mixing different types of vaccines, flu, you know, simultaneous administration or not. So I'll leave that to you guys to discuss.
Kat might want to add. We're tag teaming, but if you take a look at the guidance that other countries have put out at the present time, the very earliest guidance is that they are recommending that there is a 14-day window between the administration of a COVID-19 vaccine and any other vaccine, including flu vaccine. Now, most of those countries that give flu vaccine, they're in the Northern Hemisphere. They've already had their flu vaccine delivery done, you know, back in sort of October, November, in advance of their winter, before the COVID vaccines became registered. So it's pretty straightforward for them to say that. The clinical trials that have been done, none of them have been done giving the vaccine on the same day, the COVID vaccines on the same day as the flu vaccine. You can understand why. These are really new vaccines. So we don't, strictly speaking, have any co-administration data. And I can tell you it's very likely that the clinical guidance will say something along the lines of that 14 days. Don't lock it in yet, because you haven't seen the clinical guidance yet, but there will be a spacing. And then what that will mean is that, you know, you might have some patients, we might have in the state, some people who get a COVID vaccine first, they get their 2 doses. We know the interval for Pfizer is an interval of around 3 weeks for the 2 doses, and then they go on to get their flu vaccine. We might have other patients who get their flu vaccine first because they're later down the track and they're not yet eligible for a COVID vaccine. there's some different options, you know, a bit more of a window potentially around the AstraZeneca dosing, and that's going to come out too. And it might be that if there's a wider dose there might be possible for a flu dose in the middle of the 2 AstraZeneca doses, but that's not confirmed. So, you know, general practice is going to be doing a big job this year, you know, rolling out both flu and COVID-19 vaccines. And there's going to be some, again, really strong guidance around that, but it's, you know, a lot of it's going to be around patient flow, dedicated spaces, you know, the staff you need, all of those things that you know so much better than me.
Chris, one of the questions I have is listening to you talking about, you know, the side effects and giving the vaccine, is how we differentiate between the side effects and someone coming in with a suspected case of COVID. So there's a lot of talk around temperatures. I understand that they've got their respiratory symptoms, then it's going to be more likely it's COVID, and we would need to swab. But how do we sort out what's happening when we've got large numbers of the population having vaccines that apparently have quite a significant number of side effects? How are we going to manage that in general practice?
I'll take a stab at that. Kat, please jump in though. Look, the safety database on the reactogenicity of the 2 vaccines that we're talking about here, Pfizer and AstraZeneca, is so detailed. You know, the vaccine recipients, and there are at least like around 10,000 in each arm for each vaccine. They did an electronic diary card every single day for the first 7 days. And if you look at the data, we've got slides on this and we can show them next time, but you can see that actually, so for Pfizer vaccine, it's sore arm, not really redness or swelling, sore arm in about 90%, not even very tender. It goes up, you know, over the course of day 1. By day 2, around 36 hours is the peak of the soreness, the largest proportion of patients reporting that soreness in the arm, still mild to moderate. And then it goes down, and by about day 3, symptoms are resolved. The same time that the arm is sore is when most people have that mild to moderate temperature, headache, fatigue, myalgia. Diarrhea and vomiting wasn't different to placebo, but you know that, and a few patients actually had chills. But again, peaked at around that sort of 2nd day, and then was pretty much down to baseline rate, same as placebo, by around the 3rd day. So very clear pattern of reactogenicity in that first sort of 2 to 3 days, and then settling right down. So if you have a patient, you know, who comes in on day 3 or 4 and they've got a cough, a runny nose and a low grade temperature, I would say that's not an expected reaction from the vaccine. COVID test right there, you know. So I think we've got a lot of data on these vaccines that tell us what that profile looks like. And that same short-term headache, muscle ache, mild temperature, but resolving quite quickly was the pattern for the AstraZeneca vaccine as well. And I think that's going to make it, once you guys get experience, once we all get experience with delivering this vaccine, quite straightforward. They didn't have to test a lot of people for COVID in the trials, actually, and I don't think they're necessarily doing that in the rollout in the Northern Hemisphere.
I guess the other thing to consider in that is the staff. So if you've got staff who are getting temperatures, as you know, after vaccines, it might be useful to immunise your staff just, you know, when they've got a couple of days off or things like that, just to, you know, rule out that risk. Because we've got a staff member turning up with a fever, then we're going to be much more concerned.
Can I also add in there, Penny, that probably good to stagger your staff getting it and not doing everybody on the same day, or you might have everybody being really off and not very useful in the clinic for the day or 2.
Sorry, I just wanted to add that I think the same rules would apply as for any vaccine, that if someone was acutely unwell or had a temperature of, you know, 38.5 or above, just like with any other vaccine, you would defer vaccination. But what we're seeing in other countries is that a past history of COVID is not a contraindication to vaccination, but that people who have had confirmed COVID-19, because they may have some degree of natural immunity, and we don't know how long for, different countries are sort of recommending perhaps wait until they're fully recovered or wait a particular number of days, 30 days or so. It varies. But that's just sort of the background, that there's not really a safety concern of vaccinating someone who happens to have had asymptomatic COVID, or, you know, you've missed the fact that their slight runny nose is actually COVID. It's more a fact of making sure the vaccine is effective, because it's not going to be particularly effective if you've got current COVID-19 disease.
And if I could just put another plug in for the SmartVax SMS survey. So actually, you know, as Kerry mentioned, it goes out a few days after vaccination. We're going to reconfigure the survey for that. So what it'll do is that patients will get an SMS on the 3rd day after vaccination. So it will have captured that little window where they're going to report those symptoms. And we'll actually ask a question about whether it's interfered with their ability to go to work or do their usual daily activities. And then we normally just send one survey, but then we'll send another survey on day 8 that says, have you had these symptoms? Or if you had them before, have you recovered? And again, did it interfere with your activities of daily living, work, etc.? So the more GPs that we can get to be involved in that system, just by going to that SmartVax link, just you give them your details, they'll sign you up. It only takes about 10 or 15 minutes. Your practice manager can do it. I think you have to sign a quick form to get to the system. You can sign up just for COVID vaccines for your patients, or you can actually sign on to all other vaccines as well if you wish. I think it's going to take a couple of weeks to onboard you, because they're just getting the systems up and ready to onboard you. So it'll probably be kind of early Feb or something that your practice actually signs up. You've got a little bit of time to read the information. But if you are interested, without any obligation, if you reach out to SmartVax, they'd love to hear from you. And that data is all going to be really viewable. We're going to analyse it every single day. If you go to the ausvacsafety.org.au, you can see the data from the flu. We had 300,000 flu people with flu vaccine answer this past year.
I agree, Christine. I'd like to support that as well. I think a couple of questions have come up as to whether it's an individual application or whether it's a practice-based one, and it's definitely practice-based.
Can I say we use it? My practice was one of the very, very early adopters. So I think we were one of the first practices in New South Wales to be using it. So we've been doing it for a few years now. And can I just endorse that it's a really great system. Patients are very happy to cooperate with it. We probably get about between 75 and 85% response rate to it. And I get a daily report on the sort of what happens. So I know exactly how many reports have gone out. It's really, particularly in flu vaccine time, it's so useful, because I can instantly reassure patients who come and tell me that they're worried about adverse reactions. I can say, well, we've actually had 800 vaccines done already, and I've had no, very, very, very few people actually saying they've had any adverse reactions, etc. So I think it'll be a very reassuring thing to sell to patients as well, that you can let them know as you're getting the reports what the feedback is, and you sort of feel like you own it more when it's the patients within your own practice. It's very easy, fantastic. I would definitely encourage you to do it for more than just COVID. It's a great opportunity to invest in a safety program, because it really does give you a feel for what's happening with vaccinations in your practice.
And just to note that it's actually not compulsory. Someone's been asking if we have to have that on board to give the COVID vaccine, so not compulsory at the moment.
I suppose just to clarify, the one compulsory component is going to be uploading data to the EIR, the Australian Immunisation Register. It's going to be critical that we have that just for our surveillance as well, notwithstanding understanding how we're going roll out. It's going to be a critical part of our assurance, because we will be doing data linkage and other aspects with the EIR.
Sorry, Kerry, just to interrupt on that front, there is going to be a new requirement with the EIR. GPs, that just happens with their systems already, it gets uploaded, but there is actually going to be a new requirement with COVID, which is completely new, which we actually have to put in not just the batch number, but actually the whole, it's the higher level number, which is big and complicated. And so all practices are going to actually have to look at doing barcode entry for the vaccines as they receive them into the practice. And so it is an extra step to reassure everybody. Best practice, medical director, etc., are already on top of it, and it'll be in the newest upload for immunisation stuff. So it's there as part of the process behind the scenes. And anything else that the government does require of us as a mandatory thing will be included from behind the scenes. But we will need barcode readers, which is a new change. But don't get fussed. From what I understand, barcode readers aren't terribly expensive. They're about $85 to $150 if you actually have a standalone one. And once it's installed, it'll be really easy to use, a bit like as you're getting used to doing your barcode entry in and out of places. Sorry, back to you, Kerry.
I was also going to say that we should maybe touch on children, and perhaps again, Christine, if you could reiterate the objective, which is severity modification rather than herd immunity, and the issues around children, just to give some context.
Yeah, and I thanked Kerry, and I think Kediki really explained this at the, and as Kerry's alluded to as well, the program is designed to get us protection on board first as individuals against severe disease. I mean, we know that we won't have vaccines registered in children for some time yet. I mean, it could well be, a year, 6 months. I mean, we just don't know how long it's going to take, because there are almost no clinical trials in children at the present time. The trials have been done in either, for Pfizer, it's been over 16 years of age. So that'll be probably registered from 16 and above, which is relevant when you're talking about, young people with chronic medical conditions. And those with chronic, certain medical conditions will be prioritised. AstraZeneca's from, been largely registered from 18 years above. It's actually only been registered in 2 countries, the UK and just India 2 days ago. But importantly, the trials the trial data just isn't coming through in the kids yet, and they haven't even designed trials much below the age of 12. There's very little data in children. On the flip side, why is that? Well, of course it is because children, by and large, particularly the youngest children, have mild disease from COVID-19. They're much less likely to have, COVID disease from COVID and be ill from COVID. And we think probably, particularly the younger ones, don't transmit it very much, either. But we won't have all of those people under 18 vaccinated. So we, to get something where you have indirect protection, which is the other name for herd immunity, that's going to take that's a long game. It's going to take some time in Australia. And the program is really designed to get people protection against severe disease on board first, particularly adults who get the sickest from this virus.
Christine, can I follow up with that? So how do you see the long-term rollout of this? So, in 2025, I know that's really hard to say, but will we be routinely vaccinating with COVID in one arm, flu in the other, just for one dose? Will we have a different COVID vaccine coming out every year because there's there's some sort of shift like there is in flu? I mean, what do you think that will look like?
Yeah, look, I wish I was so clever as to predict it well, but I think we're going to be living with the SARS-CoV-2 virus in the world for years, if not decades to come. We just will be. Like, it's a highly transmissible virus. It infects people of all ages. We're going to take quite a long time across the globe to build up immunity. We're going to have to live in a modified COVID safe way for a long time. The virus is going to be with us. What will the vaccination program look like over time? Well, step one is to get as many people as we can getting protection on board. Step two is to see how long the vaccines last for. We just don't know yet. We think they're going to last for a while because natural infection seems protective for quite a while, but we just don't know whether that's going to be a year or 5 years. We just don't know. The pattern of how the virus behaves in vaccinated communities is just clearly going to change. It might settle into this seasonal pattern. Other coronaviruses that are mild seasonal coronaviruses are in that more in that winter pattern. So we might see it settling into that pattern. But even that settling is going to take a while because, you know, the world's not all going to get vaccinated at the same rate. I mean, there's one country out in front at the moment, Israel. They've vaccinated about a quarter of their population. And this messaging out of Israel that's starting to say, look, we're seeing we're seeing virus transmission go down. Well, maybe they are, but, you know, it's a bit too early to tell. And first and foremost, we want to get lots of people the protection. I think we will see more and different types of vaccines come on the board. You know, we've never sort of said these are called first generation vaccines, which isn't necessarily bad. They may be the ones we use forever, but we're seeing more technologies come through, as Ket mentioned. Will we need to change the vaccine is a question that's still very live. Right now, there is a fairly high confidence that the vaccines that we've got will protect against the emerging variants of concern, the new strains that have come out of South Africa, out of the UK, but we don't know that for sure. So researchers are looking in all the animal models that have been developed to see if they protect the animals. They're looking in the laboratory to see if it neutralises these variant strains in vitro, in assays in the laboratory. And then thirdly, what we heard recently, which is really good news, is that a number of the studies that are still ongoing, those large phase 3 efficacy studies, they will actually include patients that have had disease with the variant strains. So, you know, we heard from Novavax, for example, they're not there yet with their phase 3 data, but because they're a little bit later, they've got studies in South Africa and the UK that have those strains included. So if we're lucky, and if obviously you have to be able to do the genomic testing, you know, that you need to back that up, we might have efficacy against the original strains versus the, you know, the variants of concern as well, which is what we really need. But I don't really get the sense we're going to need to vary the vaccine, you know, like as frequently as you do with flu. This virus isn't shifting and changing as much, anywhere near as much as flu is. So long answer, I'm sorry, but so many fascinating questions and I could go on for a long time.
We love it. Thank you. Listen, Kerry, one of the questions I think that seems to be coming through here is just around the really practical side of the rollout. And you've already discussed how there'll be hubs, and that'll probably be where the first, where the Pfizer doses will be coming out of, and then the GPs will be more involved in the AstraZeneca. The questions are like, how and when will we exactly be involved? Will every general practice be involved? Will there be expressions of interest for certain clinics to be involved? Are you able to sort of elaborate any more on the actual practicalities of it?
So I suppose the staff, New South Wales Health and state health departments have been tasked with vaccinating certain categories, and it goes to Ketika's comment about the rollout strategy. So I refer you to that strategy. We're responsible for that first group, and that's looking at those people that almost are at the greatest risk of an incursion event. So the people that are likely to get infected are people that are in our healthcare facilities, that are testing people that are presenting with COVID, because we still have returning overseas travellers needing healthcare, and also people at the borders who are coming into contact with international travellers. Obviously, we've got a robust quarantine system, but nothing is foolproof, and so we want to add the layer of protection of vaccinating those workers. That's the bit we'll do. And particularly in terms of the Pfizer vaccine, because of its more challenging storage requirements being -70, it can't tolerate being out of even, it can be stored for short periods at the fridge level temperature, but again, it's not, you're not ages in the fridge. It has to be handled very carefully. So that supports a more hubbed process, where we'll initially focus on metropolitan, but then move it rurally to population centres and have people come into those, potentially with some outreach out through a hub and spoke model. The Commonwealth will be rolling out vaccine in aged care, and then later on there's clearly roles where they'll be potentially asking for engagement of general practice. And then also the question really will come is, when does this become business as usual and we vaccinate a lot of people through general practice and at what point, and a bit of that will depend on the timing of the approval and also what volume of vaccine we have and some of the logistics in terms of rollout. So I think that's why we can't paint a certain picture, but there is a roadmap which is basically saying, let's vaccinate a combination of the highest priority for us, which is clearly, aged care, given the incredible impact of that, which the Commonwealth's taken responsibility, and the states very much for the quarantine workers, and those that are across pathology and emergency departments, COVID testing clinics, the people that are most likely to come into contact with COVID.
Fantastic. Thanks, Kerry. And look, I do have to, before we finish, there's a couple of thank yous that are coming through to Kerry for the wonderful job you're doing with Gladys. And I know that I've notified you of a Facebook page that had a whole lot of thank yous to you, Kerry. So I'm going to slip that in before we finish. The other thing, though, is I do think a bit good to thank Christine and Kataki for all the work they're doing, because Christine's working just as hard, but not always as visible to GPs per se. So there's a lot of really busy, hardworking people on this call. One of the other questions that's coming through a bit is around mixing up the vaccines, and whether if you have one vaccine for the first dose, are you able to have a different one for the second vaccine? I don't know, Kataki, if you wanted to answer that.
Sure. So there isn't any data on mixed schedules. So theoretically, since they're both the ones that we're talking about, Pfizer and AstraZeneca, they're both based on the spike protein. So theoretically, there should be some sort of a boosting effect. However, it hasn't been studied. And so we haven't seen that recommended in any other country, an intentional sort of mixing the schedule. And there is an upcoming clinical trial planned for the AstraZeneca vaccine and another viral vector vaccine, the Russian vaccine. So maybe down the track we will see intentional interchangeability, but otherwise currently they are not considered interchangeable. And it is generally recommended everywhere that they're being used that you finish the course with the vaccine that you started with. But I think there may always be exceptions if there's no supply left, for example. Circumstances might lead you to give a dose of the other vaccine. But as much as possible, I think it will be the case that you finish 2 doses of the same vaccine.
There's another question coming through around mandatory vaccination for healthcare workers. Again, we may not know the answer to that.
I suppose I would just sort of say there that clearly we have taken a role, and maybe I'll just talk more broadly around when we mandate vaccinations, and we do that in very certain circumstances where for healthcare worker, New South Wales Health has a policy where you can't work in certain high-risk areas if you're not vaccinated, or if you do not get vaccinated, you may have to wear masks or personal protective equipment in the case of flu if you do not get vaccinated. We've taken a very cautious approach to mandating and really where there is a very high clinical risk and benefit, and that reflects the fact that in general, Australians take up vaccination. I think, early on, I think it wouldn't be something that we would be approaching, but clearly we've also got to consider what our policy settings are for aged care, another group where we have been mandated during COVID, mandated aged care vaccination for visitors of aged care facilities and for staff. So again, I think this is going to be a bit of a work in progress, but I would like to think that the majority of healthcare providers will trust the regulatory process, and we are in a good position to have witnessed the rollout of and learnt from very much large numbers of vaccinations that have occurred quite quickly, and I think that should give us comfort that our regulators will take due care and will have that experience from many countries who have rolled out very large quantities of the vaccine. But I don't know, Christine, if you wanted to say anything as well.
No, look, I agree. I think, it's really wonderful. We all know it's wonderful when we can have a conversation with our patients that they're comfortable with the benefit, over the risk, and that they, but I think I was just typing an answer to another question. I think the question of, you know, incentives and mandates. I mean, clearly that's got to be looked at in certain contexts, as Kerry alluded to, but you know, we have some of the highest immunisation rates in the world, best uptake of flu in the world. And I think, you know, in a wonderful primary care and general practice kind of environment. And so it's just about, I think, you know, asking the questions of your patients, hearing what their questions are, taking the time with them. You know, every time, every piece of work you put in, I think if you can vaccinate one person, I often feel like the trickle-on effect is really great. You know, you hear people say, I came back from the GP, they answered my questions. I really, you know, I've come away vaccinated. That's going to probably vaccinate another 5 people. You know, I would encourage you to jump on our website. There's some you know, options there for provider training, you know, for a package of information around immunising childhood vaccines, around some of the ways to have conversations. But you do this is your bread and butter, and I think it's really important to see this as just yet another excellent example of how we can prevent disease through vaccination.
So I'm going to hand over to Bethany, because I'm afraid we've now come to the end of 8 o'clock, and I'm glad Kerry's already been thanked along with Kataki and Christine, but I'll give to Bethany to do a final thank you.
Yes, thank you, Charlotte. And I will say a final thank you to all of you, Kerry, Penny, Kataki, Christine and Charlotte. Thank you so much for your ongoing work with COVID-19. Unfortunately, that is all we have time for tonight. I will send any resources and links that were mentioned along with the details and registration link that will for the next webinar. Thank you again, everyone. Have a great night.